Greetings all. My name is Muhammad Yasin Taha. Today I'm going to present about glioblastoma multiforme. Um, First, this is the content of this presentation. There's introduction, epidemiology, molecular and cellular pathway, current technologies and methodologies, and identifying research gap of this disease, and then propose a research idea. First, the introduction. The glioblastoma is the most common progressive brain cancer in adults. Despite the extensive therapy, it often results in poor prognosis because its rapid proliferation and aggressiveness. Glioblastoma, this is the epidemiology. Glioblastoma is responsible for 48.6 of malignancy CNS tumor and 14.5 of all CNS malignancy. GBM patients have poor median overall survival, and it's around 15 months. GBM can develop in spinal cord, brain, stem, and cerebellum, but it's nearly always found in the brain. It can be found in the for loop of the brain, 61% of primary gliomas, and there's 3% occipital, 13% parietal, 20% temporal, and 25% in the front. The incidence of GBM is 3.19 and 4.17 cases per 100,000 persons a year. And the prevalence in children and adolescents between 0 to 18 years is 0.58 per 100,000 cases. The incidence is higher in Caucasian compared to other ethnic groups, and in male more than females. Molecular and cellular pathway of this disease. First, this is the molecular basis of the disease. We have many pathways that, when it's dysregulated, it can lead to initiate the tumor. And this pathway, PI3K, STAT, mTOR, and in addition, in this pathway, there's loss of PTN, which is tumor suppressor gene. We have also NF-kappa. In this pathway, there's tumor necrosis alpha and tumor necrosis receptor 1. This lead to inflammation, and IKK complex lead to mesenchymal transition. We have also the HO pathway. There's GLI1 and truncated GLI1. We have also IGF signals. We have transcription factors such as CMYC and TEAD, and CEPP beta and PKC, which is protein kinase C. We have also JAK and STAT activation, and this is STAT3 lead to through survival genes. We have also WNT, beta-catenin, and Notch pathway. All this pathway lead to proliferation, stemness, survival, angiogenesis, invasion, and resistance to therapies. Now this is the immune pathway. In immune pathway, we have CSF1R. This signals in microglia and tumor-associated macrophages promote M2 polarization and immune suppression and evasion. We have the second one is CTLA4. This actually signals in T regulator inhibition, inhibits effector T cell by blocking CD28 co-stimulation and attenuated PI3K AKT signals. We have programmed death 1 and programmed death ligand 1. This one lead to T cell exhaustion by inhibition PI3K and AKT signals and lead to cytokines, decreased cytokines production. We have TGF beta signals. TGF beta signals promote T regulation and M2 macrophages, contributing immunosuppressive environment. We have another one is CD89 and CD73 through adenosine pathway suppress immune response by generating adenosine, which inhibition effector T cells. And the last one is IDO KR9. KR9 pathway increase immune tolerance by inhibiting T effectors cell functions and promoting T regulatory cells. Now this is the current and emergency therapeutic strategies for glioblastoma. We have the surgeries, which is the key components of glioma treatments, radiation, gamma knife, radiosurgery is still very accurate technique, laser interstitial thermotherapy and this one used for the patient who have incurable and recurrent malignancy. Focus ultrasound by temporarily breaking the blood-brain barrier to improve targeted medication to deliver and enabling thermal ablation. Tumor treating fields represent harmless when used with conjunction with temozolomide, considered extended survival by disrupting mitosis and using alternated electrical field. We have chemotherapy such as temozolomides and additional other targeted treatments treating oncogenic signal pathway and have demonstrated variation in clinical and preclinical benefits. The last one is immunotherapy. We have BDL1 and CTLA4 inhibitors, which is called immune checkpoints inhibitors. New strategies. We have stem cell therapy. Developing of stem cell therapy is an innovative techniques or strategies to treatments GBM, providing a variable solution to significant therapeutic obstacles such as immune evasion, tumor heterogeneity, and blood-brain barrier penetration. To increase immune cell recruitments and anti-cancer efficacy, neural stem cells have been engineered to release immunostimulator cytokines such as interleukin 7, 12, and 23. The last one is oncolytic virus. An oncolytic virus offers promising approach to overcome the inherently called, which is called a cold tumor microenvironment in glioblastoma. The cold tumor is characterized by low immune infiltration and T cell exhaustion and immunosuppressive tumor-associated macrophages that limit immune therapy efficacy. GBM become an immune responsive to tumor when OBV specifically infect and lyse the tumor, causing immunogenic cell death and producing damage associated with molecular patterns. Now I'm going to talk about the research gap. As we talked before, the GBM is cold tumor, so all the immune checkpoint inhibitors are not work. So these immune checkpoints such as BD1 and BDL very low cytotoxic cell infiltration. One of the main obstacle to successful immune checkpoint inhibitor response to immune suppressive environment. Moreover, it's challenging to maintain anti-tumor M1 phenotype in the tumor microenvironment because tumor-associated macrophages in GBM are highly degree of phenotypic plasticity and frequently take onto pro-tumor M2. The failure of to permanent polarization associated macrophages toward an anti-cancer M1 phenotype is crucial unfulfilled required in glioblastoma immunotherapy. While immune checkpoint inhibitor elevate inhibitory signals in T cells and oncolytic virus increase immune cell recruitment, either strategies provide persistent immune stimulatory cues necessary to prevent macrophages reversion from M1 to M2. Strong type interferon response in an innate system activate are possibly when cyclic GMB and AMB sensitized stimulatory of interferons genes, and this pathway called STING. This pathway is still unknown if the signal can maintain M1 polarization when it's combined with OV, oncolytic virus, or immune checkpoint inhibitors. Proposed research idea looking anti-tumor macrophages polarization to overcome immune resistance in glioblastoma using STING primate, oncolytic vaccine, and immune checkpoint inhibitor combination. The hypothesis is continuous activation of the STING pathway can maintain tumor-associated macrophages in M1 anti-tumor state, preventing their repolarization to M2. This sustained vaccine-driven inflammation supporting durable T cell tumor clearance via immune checkpoint inhibitor and glioblastoma. Rationale: current immune checkpoint therapies or immunotherapies often fall short because the temporary immune activations in highly adaptable myeloid-rich tumor microenvironment. While oncolytic vaccine trigger local inflammation and immune checkpoint inhibitors activate T cell, neither sustain the innate immune signals need to fight metabolic on cytokines-driven reprogramming M2 Sting agonists stand for their ability to continuous induce type 1 interferon signals, making them a promising candidate for maintaining tumor-associated macrophages and M1 state. The objectives of the research will be the first one, the initial goal is to determine if M1 macrophages polarization in GBM microenvironment is stabilized by STING agonist treatment. Following treatments with the STING agonist alone or in conjugation with the oncolytic vaccine, macrophages phenotype, transcriptional programs, and metabolic profile will be evaluated using synergic and patient-driven GBM models. The second one is we will measure tumor burden, survival, immune cell infiltration, and functional T cell responsive to assess the therapeutic efficacy of triple combination of STING agonist and anti-PD-1. This investigation will ascertain whether STING activation increases response to immune checkpoint inhibitors and prolong OV-induced inflammation. The last one is we'll use single RNA sequence and conceptual immunological profile to find biomarker linked to long-lasting M1 polarization and treatment response. And thank you for your attention. If you have any questions, don't hesitate to send to me an email in my email address. And this is the reference.